Good evening, everyone, and welcome to today's session. YouTube is a great invention in the world that enables free learning anytime, anywhere. We were supposed to start the pediatric session at 6 p.m., but suddenly YouTube outage, never heard, right? So YouTube and Gmail started working for the world. So we got delayed a bit, but every day evening, please don't forget to log into youtube.com/onlinembbs, which is the best place in the world where you can get every day 6 p.m. an hour Chai Pe Charcha with Dr. Murali Bharadwaz. And don't forget to join our 150 hours live online NEET PG crash course, where you get 150 hours live class, 427 hours of HD video, almost 1500 videos, 10,000 PowerPoint slides, 30 NEET PG full-scale grant tests, and 10,000 MCQs on the quiz tournament app, Incus. All this for a most irresistible price of just 10,000 bucks. So starting from December 13th to the March 14th, in this next 90 days, you are going to have a crash course revision. So let's make the great beginning, Doctor, where we have started the game the other day. So in pediatrics, there are about 600 hottest MCQs. I'm going to give you a revision before Saturday, so that most of the basics, fundamentals, we will be able to do the revision. Good to see 7 online students. Can you please punch whether the voice is loud and clear? Please drop a line in all your WhatsApp, Telegram groups so that we can roll the wheel. A patient presents with left ventricular hypertrophy, left axis deviation. What is the congenital heart disease which lead to development of LVH? Very simple. Right atrium to right ventricle, right ventricle. This is left atrium, left ventricle. Assume there is a tricuspid atresia. The blood cannot flow easily from right atrium into right ventricle into pulmonary artery. So what will it do? It will move from right atrium into left atrium. Left atrium receives the regular blood and also the shunted blood. Together will lead to left ventricular hypertrophy, leading to left axis deviation. So tricuspid atresia is one among the 4 T's that you need to remember for the cyanotic heart disease in the pediatric population. T for TOF, T for tricuspid atresia, T for transposition, T for total anomalous venous circulation. Out of these 4 T's, tricuspid atresia, how do you suspect? Number 1, when there is a tricuspid atresia, there is a decreased blood flow from the right atrium to right ventricle into pulmonary artery. That's the reason tricuspid atresia leads to pulmonary oligemia. So cyanotic heart disease with pulmonary oligemia. 2 T's you should remember. One is tricuspid atresia. Second, tetralogy of Fallot also has pulmonary atresia. So that is the reason the blood flow to the lungs is very oligemic. So in summary, you can remember cyanotic heart disease, whenever it is there, you should remember 4 T's. TOF and tricuspid atresia. then TA-PVC and transposition of the great arteries. Out of these, TOF and tricuspid are associated with pulmonary oligemia, decreased blood flow to the lungs. Whereas TA-PVC and TGA are associated with pulmonary plethora is what you need to remember. Then within TOF and TA, how do you differentiate? TA is associated with left ventricular hypertrophy, left axis deviation. TOF is associated with right ventricular hypertrophy. That is a differentiator between the two, is what you need to emphatically remember. So whenever there is a cyanosis with left axis deviation, left ventricular hypertrophy, then you should have a high index of suspicion as a pediatric cardiologist that it is a case of tricuspid atresia, is what I want to underscore to all of you. So these are all the fundamental favorite MCQs in the exam. If you know that right atrium is on right side, left atrium is on left side, that's all. You can become a cardiologist. If you know your right hand is on right side, left hand is on left side, you can become a cardiologist. So that is what I want to tell you. When you prepare for entrance exam, always have that high hopes, high spirits, high energy. Don't look back. Start repenting. Oh my God, I wasted my time. There's a lot to read. Even in MBBS also, I did not read. I did not see all these cases. How I am going to crack this entrance? No. Say goodbye to all those negative thoughts. Every day, evening 6 p.m. to 7:30, 8 p.m., Dr. Murali Bharadwaz is there to give you an intrathecal injection of inspiration for you to pick up and then start with high energy. Right, Doc? We have a deal. So also bring your classmates, friends also every day 6 p.m. with Dr. Murali Bharadwaz. Pot shunt, water shunt, all the shunts you should know. So descending aorta to left pulmonary artery is the pot. So there are three important shunts you should remember. Blalock-Taussig's operation. So what does it mean? Blalock-Taussig's operation. The right subclavian artery, right pulmonary artery between the two. Subclavian and pulmonary artery. You are making a bypass. So subclavian is systemic circulation, pulmonary artery is pulmonary circulation. Between the two, you are creating a conduit. Now, pot shunt. Descending aorta with pulmonary artery. Water shunt. Ascending aorta with pulmonary artery. How will you remember? Pot. If you take a pot, from the pot, the water will fall down. So remember, descending aorta with pulmonary artery. Water shunt, water strength. So a fountain, you remember a fountain from which the water is moving. It will be ascending up. So ascending aorta to the right pulmonary artery is basically water stents, is what you should remember. So subclavian to pulmonary artery, Blalock-Taussig. And this is the classic Blalock actually. And the pot's shunt is to the descending aorta. Water shunt is between ascending aorta and the pulmonary artery is what I want to underscore to all of you. A neonate is having recurrent attacks of abdominal pain, irritability, diaphoresis on feeding, non-specific murmur. He is at risk of MI. What is the diagnosis? You should remember anomalous coronary artery. So there can be a lot of variations in the coronary artery. Normally coronary artery arises from aorta. But it may originate anomalously from pulmonary artery. So in that case, there can be a coronary insufficiency leading to MI is what I want to underscore to all of you. A child is aged 2 years, anemia, target cells, very important. भैया टारगेट क्या होता है? सेंटर में ज्यादा होता है. So target, right? So where do you see? He also has hypochromic microcytic picture and a hemoglobin of 6. So how do you want to evaluate? So always remember target cells, thalassemia. You need to remember. So target cells are also called podocytes. There is a lump of RBC. There is a lump of hemoglobinized cytoplasm inside the RBC. It is pathognomonic of beta thalassemia major is what you need to remember. Very good to see 13 online classmates. Please invite some more of your friends. Every day evening 6 p.m. Today 6 p.m. we are about to start, but YouTube suddenly we got an outage. It is like Parampita, Paramatma suddenly disappearing from the faith. So world runs on YouTube and Gmail, right? So both of them had an outage. That's the reason we could not start at 6 o'clock. But otherwise, Monday, Tuesday ho, yeah, Saturday, Sunday ho. 6 p.m. evening, you have Dr. Murali Bharadwaz spending time with you. Chai pe charcha. Until March 14th, I'm going to hold your hand in this crash course. So please don't forget to subscribe yourself to this crash course. So in this crash course, you get 427 hours of high density video. Totally 1500 video lectures on the onlinembbs.com. That will revise all 19 subjects very fast. 10,000 MCQs. Sorry, 10,000 PowerPoint slides of notes. Then 150 hours of daily live broadcasted session. Then to inspire you every day. You will also get 10,000 MCQs in the form of quiz tournaments that you can be able to play on the and on the Incus quiz app. So these are all the things that you get. So all for a small throwaway price. So please call our helpline 9000-868-356 in order to take a subscription on the onlinembbs.com and Incus quiz app. So iron deficiency anemia, any hemoglobinopathy, target cells will be there. What is the most common cause of meningitis? Please keep punching your answers, doctor, into the chat window. Between the age group of 6 months to 2 years. It is the H. influenza, which is the most common organism. Then seborrheic dermatitis, lytic skull lesions, ear discharge, hepatosplenomegaly. What is your diagnosis? Histiocytosis X. So these are the lesions which are called seborrheic dermatitis. Seborrheic dermatitis. It is also called cradle cap. So seborrheic dermatitis, calvarial lytic lesions, ear discharge. So these are the characteristic features which you need to remember. Very good to see Ritu Raj, Sandeep Vemula, and many more who are all online. Very good. What is true about cretinism? Cretinism, there are short limbs, short stature. So typically dwarfism is divided into proportionate and disproportionate dwarfism. So whenever the proximal part is shortening, rhizomelic. There can be short metacarpal, short phalanx, trident hand, varus deformity, shortened long bones, anything. So proportionate Disproportionate में होता है short limb and short trunk. So you should remember what are the causes of each of this type of growth, retardation and dwarfism. Favorite MCQ of the examiner. So any skeletal dysplasias, metabolic bone disease, disproportionate. Then it can be proportionate. Proportionate में दो चीजें होता है, which you need to remember. Prenatal onset like IUGR because of the placental dysfunction, infections, teratogens, dysmorphic syndromes, chromosomal disorders, they're all prenatal and proportionate. Any chronic diseases like renal, hematological, gastrointestinal, malnutrition, drugs, endocrine disorders, they're all proportionate dwarfism. That's what you need to basically remember. Now, what are the manifestations of endemic cretinism? So, endemic cretinism can present with strabismus and spastic diplegia. So, mental deficiency, deaf mutism, squint, spastic diplegia. There can be neurological endemic cretinism. Then myxedematous endemic cretinism will be mental deficiency, hypothyroidism and dwarfism. So that's what you should remember. A 10-day-old male, pseudo-hermaphrodite child, blood pressure is 110/80 only, no hypertension. What is a likely enzyme? 17 alpha hydroxylase deficiency. Doctor, you will all remember me in the tomorrow's exam hall. Why? Because this is the God's most favorite topic in NEET PG exam. Congenital adrenal hyperplasia. We have discussed this extensively in the online MBBS.com video library, which has 427 hours of video lectures, totally 1500 HD videos available for you. As a part of this crash course, when you subscribe, you get all that. Please take an extensive chance to do the revision. Acha, doctor, this is something that you need to एक फुटबॉल ले लो और मन में रखो, याद रखना. In congenital hyperplasia, first thing, BP raised, BP not raised. BP raised hypertension happen in 11 beta and 17 alpha. BP normal in 21 alpha. But when 11 beta is there, if it is male, normal genitalia, but in female, clitoromegaly leading to ambiguous genitalia. Whereas in 17 alpha, testosterone will be low. That's the reason males will have undescended testis, ambiguous genitalia, whereas female it is normal. Right? You will take a small screenshot of this and keep it. And आपके book में लिख लो, क्योंकि definitely आने वाला MCQ है. You can call it as Murali Bharadwaz Sir, guaranteed MCQ in tomorrow's exam. And such a guaranteed MCQ, if you answer, you are ahead of 10,000 other NEET PG aspirants. आगे बढ़ सकते हो. अगर आंसर नहीं कर पाए तो CH मुरली भरद्वाज सर के लिए अपमान है. The soul of the Dr. Murali Bharadwaz will be heaving in graveyard. Oh my God, why my students did not answer? There are some topics like Liddle syndrome, Bartter syndrome, Gitelman syndrome, renal tubular acidosis, CAH. If you are the students of Dr. Murali Bharadwaj, उसको छोड़ेंगे नहीं एग्जाम में, अगर आ गया तो पकड़ेंगे और सीधा तीर चलाएंगे, राइट? लाइक द स्कड मिसाइल्स, थार के तलवार के तार के जैसे आपका precision of answering in the tomorrow's exam should be, if you are Dr. Murali Bharadwaz students. Now, BP is not increased. Matlab, it is a salt-losing congenital adrenal hyperplasia. In fact, they'll have failure to thrive. So in them, if it is female, there is ambiguous genitalia, but in male, normal, but later, they will have precocious puberty. So डॉक्टर एक ही बात याद रखो, एक होता है एल्डोस्टेरॉन, दूसरा होता है टेस्टोस्टेरॉन. सिंपल निमोनिक बना बताओ भाई किसमें क्या होता? 21, 2 और 1. जहां भी 1 होता है वो एलिवेट होता है. सो प्लीज डोंट फॉरगेट, जहां भी 1 होता है वो एलिवेट होता है. सो इसलिए 21 लगाए तो 1 किसको मिल रहा है? टेस्टोस्टेरॉन को. सो दैट गेट एलिवेटेड. 17 अल्फा 1 होता है aldosterone position में. That's the reason aldosterone is elevated in 17 alpha. That's the reason they will have hypertension. 11 beta लिए तो they will have 1 both the positions, both testosterone elevated, aldosterone elevated. Because aldosterone is elevated, typically they will have hypertension. Because testosterone is elevated, if it is a female child, then they will have clitoromegaly and ambiguous genitalia. That is what you need to remember. So how do you treat congenital adrenal hyperplasia? You have to give glucocorticoids, hydrocortisone 20 milligram per meter square per day, 8 hourly, to all infants suspected to have 21 alpha hydroxylase deficiency. And the stress dose is 30 to 50 milligram per meter square per day. But if it is a 21 alpha hydroxylase deficiency like salt wasting congenital adrenal hyperplasia, लिख लो 100 pages notebook में definitely आने वाले क्वेश्चन है बाबूजी. Fludrocortisone need to be given. So when will salt wasting crisis happen in CAH? Typically between 5th to 14th day of the life is what you need to remember. So once more, doctor, this is the most important table. You need to remember 21, 11, 17. And in which case mineralocorticoids elevate, in which case the testosterone elevates, you ought to be very sure. So how do you treat Kawasaki disease, doctor? IV immunoglobulin. There is not much of role for steroids. So already we have discussed in the online mbbs.com video library, in pediatrics, and also in biochemistry, हमने extensively discuss करके दे दिया. So please don't forget, today only take a subscription into this crash course. 427 hours HD video is available. So डॉक्टर कावासाकी डिजीज का मेन ट्रीटमेंट होता है IV immunoglobulin 2 gram per kg over 8 to 12 hours is what you have to administer. A neonate with whiteout lung hyaline membrane disease, PO2 75, F5O2 he is on 70, and the rate of the ventilator is 50 per minute. What do you want to do for this kid? भैया examiner पूछ रहा है आपको, what should be the ventilator settings in hyaline membrane disease? Always remember, oxygen is a drug. Oxygen is also poison. Don't forget, oxygen is a drug. Same time, oxygen is also poison. Hyperoxemia lead to such a worsening free radical injury to the lungs and lead to irreparable damage. That's the reason You have to be doubly sure, doubly careful whenever you are administering oxygen to the patient. So, भैया examiner पूछ रहे हैं, what should be the ventilator settings in a baby with hyaline membrane disease? So the ventilator rate 60 breaths per minute. Inspiratory time 0.3 seconds, expiratory time 0.7 seconds. PEEP should be 5 centimeters. Oxygen is set to maintain a saturation between 88 to 95. Peak inspiratory pressure should be 20 to 30 centimeters water. You want to become pediatrician or not? कल के नीट पीजी एग्जाम के लिए ये सब चीजें आप बाई हार्ट करना पड़ेगा. So if the patient is on CPAP, pH should be less than 7.2 or PO2 less than 40 or PCO2 more than 60 or base deficit more than 10. They are the criteria. FiO2 should be kept more than 60%. Now, doctor, 12 weeks old infant, आप USMLE लिख के अमेरिका जाओ या नीट पीजी लिख के भारत में रहो, डेफिनेटली पूछने वाला क्वेश्चन क्या होता है पीडियाट्रिक्स में? डेवलपमेंटल माइलस्टोन्स. अगर डेवलपमेंटल माइलस्टोन्स का बट्टी नहीं मारे तो you are not worth going to the NEET PG exam. अगर मिस्टेक करे तो एक क्वेश्चन में एक 50,000 लोग आपके ऊपर से आगे बढ़ेगा. So I used to hate this topic of developmental milestones. But what we can do? That's a problem for every NEET PG aspirant. There should be some funny way, regular way of revision until exam, right? So you should remember, typically 12 weeks old infant. Will he vocalize? Will he babble? Will he raise the head? All these things you should know. So doctor, please remember, crying is what we know. Newborn period से हम रोते रहे. 1 to 3 months, cooing, laughing, distinct crying to indicate hunger, anger, discomfort, and vocalization in response to speech. 4 to 6 months, single syllables, ba, ga, ma, sa. So 4 to 6 months. He babbles with duplicated syllables, 6 to 8 months. Ba, 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 da, 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 6 to 8 months. And he attempts to imitate the sounds. 8 to 12 months, babbles with multiple syllable types. Bagadabu, dabugu, etc. So babbling is produced with sentence-like intonation between 8 to 12 months. So it is always very interesting. Sandeep is asking a question. Sir, is there any mnemonic for developmental milestones? Developmental milestones, you need to remember in a funny manner. That is the purpose of going to a reading room, right? So a list banana, some things we will naturally remember. I don't know why. Some numbers we naturally remember. When his pins are grasped, etc. But some things we need to practice by heart. Batti marna hai. So this table है ना डॉक्टर, आपके सबके सारे बुक्स में अवेलेबल है, मगर यहाँ दिमाग वाला बुक है ना, ये बुक में बिठाना इम्पोर्टेंट है. Kallu, 2-year-old working, weighing 6.7 kgs, presents to the casualty with a history of vomiting, diarrhea for the last 2 days. So what is the interpretation of the skin pinch test in this child? This is a beautiful question. एक बात याद रखना, जो पीएम प्रोटीन एनर्जी मैलन्यूट्रिशन के छोटे बच्चे हैं, infants, elderly, scar, Ehlers-Danlos syndrome, skin turgor is not a valid way to do the assessment. That is what examiner is trying to ask you very, very clearly. ऐसे क्वेश्चंस को एग्जाम हॉल में पहले बार देख के आसमान में देखते हुए आइंस्टीन के जैसे सोचना शुरू करे तो कुछ भी नहीं मिलेगा, समय व्यर्थ हो जाएगा। सो अभी मालूम होना है आपको। सो दैट्स द रीजन आई ऑलवेज टेल यू डॉक्टर, देयर आर सॉलिड 10,000 MCQs you have to master. So in the Incus quiz app, we provided them as quiz tournaments. So please take every opportunity to do a revision. Similarly, there are 10,000 PowerPoint slides of notes of high-yield facts that we provided on the online mbbs.com video library. Then 30 full-scale NEET PG grant tests we provided in the online mbbs.com. In addition to 150 hours of this daily live online interactive session from December 13th yesterday to March 14th, 150 hours I will be there with you to handhold you to become your classmate, roommate, to make you to do the revision and study. That is important, doctor. With reference to the respiratory distress syndrome, so you should know how to differentiate RDS from that of neonatal pneumonia, from that of transient tachypnea of newborn. Between the three, you should know how to differentiate. So you should remember, respiratory distress syndrome is a problem when surfactant is not produced in a preterm baby before 34 weeks. If there is a maternal diabetes, all that hyperglycemia of the mother will go to the fetus, and fetus insulin will increase, and hyperinsulinemia in the fetus will prevent the production of the surfactant. That's the reason it's more common in babies born to the diabetic mothers. It can lead to cyanosis, but don't give 100% oxygen. Oxygen is a drug. Oxygen is a poison. That's what you need to remember. Congenital rubella. What are all the garden variety of clinical presenting features? Keep punching your answers, doctor. Please don't forget. So tell all your friends in WhatsApp group, whichever group you are in, every day 6 p.m. Monday to Friday, 6 p.m. to 7 p.m. Then Saturday, Sunday, 6 p.m. to 8 p.m. You have free YouTube session with Dr. Murali Bharadwaz. Whether there is earthquake or whether there is a tornado or tsunami, you will have a session with Dr. Murali Bharadwaz live broadcasted on youtube.com/onlinembbs. So please invite your friends. There is a schedule. This week, pediatrics. Next week, another subject like that. So if you want the schedule, please call 9000-868-356, our helpline, and please take the schedule of that. So doctor, before we start everyday evening session, we will give you 50 MCQs like a quiz, PowerPoint slideshow. Every 12 seconds, one question will be rolling, and try to punch your answers and get that adrenaline rush. Whatever be your preparation, just participate in that PowerPoint slideshow quiz and punch your answers. That way you get charged, right? After that, I come and we will have a discussion. So you should remember, doc, deafness, PDA, mental retardation, they're all the features. 8-year-old with bilateral cervical lymphadenopathy, plasma, lymphoid, plasmacytoid cells, which are more than 20%. That is the clue to say that this is TB. So the dominant cellular player in pulmonary TB is the tissue macrophage, which is being joined by the lymphocytes and plasma cells. What are the most common genetic cause of the liver disease in children? Alpha-1 antitrypsin deficiency, genetic cause. It is the neuroblastoma that frequently will have metastasis to the bone. A 6-month-old girl, recurrent UTI, bilateral grade 4 vesico-ureteric reflux. Once more, doctor. Partial-urethral valves, vesico-ureteral reflux. These two are the favorite topics of the examiner. Good to see Muhammad, Mukhtar and many more who are all online. You made my day by joining this evening session. Please do come every day evening 6 p.m. So doctor, ureteric reimplantation. So whenever there is any renal scarring is present, whatever be the grade, doctor, if the age is more than 1 year, surgery should be done. So you have many surgical options, of course. So how do you select which surgical procedure I want to do? If it is a unilateral grade 4 vesico-ureteric reflux in a 15-month-old child with a small bladder capacity, in such people, they are a typical case for extravesical implantation. Whereas bilateral grade 4 vesico-ureteric reflux, child older than 2 years, good bladder size, then you do Cohen's reimplantation. So that's what you need to remember. So what is the most common cause of the ambiguous genitalia in a newborn? 21 alpha hydroxylase deficiency. So one very important point you need to know, doc. 21 may 1 comes second, 11 may 1 comes second. So in both of them, testosterone. You remember that mnemonic just before I told now? Aldosterone, testosterone. Testosterone second position में 1 जब भी होता है, testosterone is high. First alphabet में 1 कहाँ होता है? 11 alpha hydroxylase में. Only there aldosterone is high. So both 21 and 11 have high testosterone levels, but 11 also has aldosterone high. That's the reason it leads to hypertension. So the most common cause typically is 11 alpha hydroxylase deficiency. Transient myeloproliferative disorder leading to AML is a risk factor in Down syndrome. Noonan syndrome, what do you see? Hypertrophic cardiomyopathy, cryptorchidism, and autosomal dominant transmission. So you should know the garden variety of presenting features of Noonan. Deafness, motor delay, bleeding diathesis, HOCM, ASD, VSD, and pulmonic stenosis is what you need to remember when we talk about Noonan. Noonan is the male counterpart of Turner. So you also have dysmorphic features in Noonan, hypertelorism, downward eye slant, anti-mongoloid slant it is called. A low set posteriorly rotated ears, short stature, short neck, webbing, epicanthic folds, etc., etc. A 5-year-old boy, 18, loose stools. He is irritable but drinking water. अगर मुंह से पानी जा रहा है तो ORS की आंसर बनेगा. You can still give ORS until the baby is able to drink water. 15-year-old healthy boy, he developed a pruritic erythematous blotchy areas after eating a seafood. That's a classical story of localized anaphylaxis. 45-day-old infant developed icterus 2 days later. He developed acute liver failure. He is HBs AG positive. Mother is also HBs AG carrier. So, what is it like? When will mother transmits to the fetus? If her hepatitis B virus is highly infective, how do you know that? Envelope antigen positivity is an indicator of the high infectivity, is what you should know. Then one more way of asking the same question by the examiner is, 2-month-old boy slipped into encephalopathy. The mother is known to be hepatitis B carrier. What is the most likely serological profile? So obviously both surface antigen and envelope antigen need to be positive. Now 5-year-old boy detected with HPS AG on 2 separate occasions. And the child was given a recombinant hepatitis B vaccine at the age of 1 year. His mother was treated for chronic hepatitis. How do you want to evaluate this child? So you see how important is hepatitis B in pediatrics. Hepatitis B ऐसा topic है, नहीं पढ़ के गए तो you are not a student for NEET PG. Microbiology में आता है, जनरल मेडिसिन में आता है, पीडियाट्रिक्स में आता है, गाइनॉक्स में आता है. इतने जगह पे आए तो अगर नहीं पढ़ के गए तो प्रिवेंटिव मेडिसिन में आता है. So you can escape one or other places, but not in all the places, right? So make a list. What are those 400 to 500 topics inevitably you have to prepare? If you don't prepare, results will not improve. Last year भी वही rank आज, this year भी वही rank रहेगा. अगर आप, if you don't know what is the definition of foolishness? Repeatedly doing the same thing and expecting different results. So इसलिए भैया आप क्या करना बोले तो your heart consciousness, your mind knows what topics you are good, what topics you are not bad, what topics you are dumb. एक लिस्ट मारो. अगर आपको लिस्ट चाहिए तो प्लीज कॉल अवर हेल्पलाइन. आई विल सेंड यू 957 मस्ट रीड हाई यील्ड टॉपिक्स का लिस्ट मिल जाएगा आपको. हमारे हेल्पलाइन को कॉल करो. उस लिस्ट में से टिक मारो कितना टॉपिक्स आप डम्ब है, गुड है, बैड है. जो डम्ब है उसको फर्स्ट प्रायोरिटी में खत्म करना रिविजन, राइट? सो 8-year-old boy has abdominal pain, bloody diarrhea, Mantu was negative, and sigmoidoscopy was normal, and he was passing urinary stones. What is the possibility? Mantu negative, so unlikely to be intestinal TB, but passing urinary stones. That is the clue. That is the secret clue. What is your answer? Crohn's disease. Now, doctor, why Crohn's disease patients develop oxalate renal stones? Oxalate renal stones. Why do they form? Crohn's में होता है ileal dysfunction because of ileocolitis. Ileum is the place where fatty acids, bile salts are absorbed. So they are not absorbed. And they all go and bind with calcium. So calcium is not available for binding with oxalate. And that unbound oxalate is delivered to the colon, where it is absorbed. And that leads to hyperoxaluria. So glyoxylate, calcium oxalate जो है, in the intestine, if it is not absorbed, it will enter into the blood, it will go into the kidney, and that forms the calcium oxalate stones, is what you typically see. So, फटाफट बताओ, hyperoxaluria, what are the causes? Any low calcium diet, if calcium is not available to marry oxalate, oxalate will go and stray with anybody. Any increased intestinal calcium absorption, as seen in hypercalciuria, even absorbed bhi ho gaya to it is not available to bind with oxalate. Any malabsorption syndromes like Crohn's disease, jejunal bypass, cystic fibrosis, surgical bowel resection. Whenever calcium is not available to bind with oxalate, oxalate will enter the blood and that will go to the kidney and form the stones. 7-year-old girl from Bihar, 3 episodes of massive hematemesis. Already yesterday only we discussed. If you missed this, please go back to the yesterday's YouTube video, right? Non-palpable liver, mild ascites, no jaundice. No jaundice, that is a clue. So that is classically portal hypertension due to extrahepatic obstruction, which is the most common cause for the development of the portal hypertension. Pyuria. There can be infection without pyuria, there can be pyuria without infection. Pyuria without infection is called sterile pyuria. And you should know what are the causes of sterile pyuria. Common causes pehla. STDs, especially chlamydia. Postmenopausal ectopic vaginitis, balanitis, prostatitis, appendicitis, diverticulitis, renal calculi. And non-urological conditions like pneumonia, any of them can lead to the development of sterile pyuria. So you should know what are infective, non-infective causes. So how do you define significant pyuria in pediatric population? More than 10 WBC in uncentrifuged sample, more than 5 WBC in the centrifuged sample. That is the definition of significant pyuria. Xanthogranulomatous pyelonephritis. Both adults में होता है, children में होता है. 1-2 points इसके बारे में आपको याद रखना. In children it occurs younger than 8 years, true. It affects kidney focally. Boys more than girls. Clinical presentation is similar as in case of the adults. They're all true. So doctor, you should know, in pediatrics, how does xanthogranulomatous pyelonephritis present? The most common form affects boys and girls equally and involves the entire kidney. And the other form is more frequent in girls, localized and may mimic a tumor. And it can present with flank and abdominal pain, fever, growth and weight retardation. It can present like a palpable abdominal mass. Bacteriuria, pyuria can be there. E. coli is the most common organism. Whereas in the case of the adults, typically xanthomatous pyelonephritis is middle-aged women. Recurrent UTI, flank pain, fever, malaise, anorexia, weight loss. A unilateral renal mass usually palpated. And pyuria, bacteriuria will be there. So that is a presentation. E. coli, Proteus mirabilis, Pseudomonas, Enterococcus, they are all the organisms. Abdominal mass in neonates. Multicystic dysplastic kidney is the most common cause in neonates. Age group is important. It's more common in the left kidney, in the boys, and it undergoes involution, and there is no risk of any renal cell carcinoma. That is the story of multicystic dysplastic kidney. 10-year-old girl, swelling of one knee joint. What is the possibility? TB, juvenile arthritis, villonodular synovitis. They're all the causes presenting with unilateral knee joint swelling is what you should remember. A 1-month-old baby with frequent vomiting and failure to thrive, there is moderate dehydration. Sodium 122, potassium 6.1. What is your diagnosis? So obviously you should remember that aldosterone, testosterone. 21-alpha hydroxylase deficiency is a salt-losing type of CAH because of the mineralocorticoid deficiency. That's the reason sodium is low, potassium is high. Now, a 40-year-old lady delivered a full-term baby. What do you see here? Clitoromegaly, classically. So hypertrophied clitoris. 2-month-old baby with jaundice with clay-colored stool with liver is 10 centimeters, spleen is 3. How do you want to evaluate? Obviously, peroperative cholangiogram will enable you to know to delineate the underlying cause for the development of the obstructive jaundice. A 2-month-old child, what can he do? Doctor, once more, क्या आ गया? Developmental milestones का भूत आ गया. One other way is भूत को आप काबू में लेना. That is very important. चलो शुरू करेंगे तंबोला. Pediatrics तंबोला with Dr. Murali. एक राउंड फटाफट रिवीजन करेंगे क्या डेवलपमेंटल माइलस्टोन्स को? तैयार हैं? चलो मैं जरा I'll get some water. Please be online. Six weeks, he raises the head to 45 degrees in prone position, symmetrical movements, ventral suspension. If you do, the head is at the same level of the body. That is 6 weeks. At 3 months, he gets a complete head control, no head lag. And if you put him on a prone position, they can symmetrically lift the head and shoulder about 45 degrees in prone position. At 5 months, no head lag. The Landau's reaction matures. Lateral postural control. Primitive reflexes are no more there and he rolls from supine to prone position. Prone hota hai? Prone. Press is prone. Sup is supine. When palm is facing up, it's called supine. At 6 months, he bears his weight on his hands with extended arms and raise of the head and chest above the ground. And sitting with support, remember 6 months. 8 months, sitting without support is what you need to remember. And he rolls from prone to supine. At 9 months, parachute reflex will start. He rolls back to front, crawling on the abdomen, pull to stand. At 10 months, he stands with support, walks around the furniture. At 12 months, he stands without support, walks unsteadily and sit from the lying position. एक दो तीन कदम डालना कब आएगा? First birthday को आना है. At 15 months, he is able to get up alone from sitting position and walk alone steadily. At 18 months, he can run and kick a ball. He creeps downstairs and climbs upstairs step by step, step by step. At 2 years, भैया समझो, आपको नीट पीजी में टॉप रैंक मिल गया, शादी कर लिया, एमडी में ज्वाइन हुआ. जब आप एमडी के सेकेंड ईयर में हो तब क्या होता है? If you produce the child while you are preparing for NEET PG, he will be walking up and down the stairs with 2 feet per step. At 3 years, he walks upstairs with 1 foot for each step, downstairs with 2 feet for each step, and he can drive tricycle. At 3 years. 3 years go tricycle. At 4 years, he can stand on 1 foot for 3 seconds. He stands on tiptoes, is what you need to remember. Then there are some fine motor skills on which questions come. At birth, he will be blinking to light. He follows the object from midline. Grasp reflex is there. At 6 weeks, he follows moving object or face by turning the head. At 3 months, he reaches out to the toys and he has got a palmar grasp. And he follows the object from the midline through a range of 180 degrees. At 6 months, he will be handling object and transferring from hand to the mouth, called mouthing, and the palmar grasp will disappear. At 9 months, there is an immature pencil grasp by 3 fingers and thumb, and he can use the thumb and fingers to pick up the cube. At 12 months, he will be pointing to an object with an index finger. Why did you produce me into this cruel world with the NEET LKG entrance exam? He will be asking you. And he will be doing mouthing of objects. At 15 months, he will be doing linear scribbling, building tower of 2 cubes. This is one of the favorite MCQ of the examiner. At 18 months, a tower of 3 cubes. And at 2 years, draw a line. 3 years, draw a circle. 4 years, draw a cross, draw a square. 5 years, triangle. So remember, line, 2 years, circle, 3 years, cross, 3.5, square, 4 years, triangle, 5 years. 1 MCQ आएगा कल के एग्जाम में. एक फुटबॉल ले लो, सारे बुक्स में है जहां पे ना, मगर नवाब साहब ये सबको याद रखने में इंपॉर्टेंट होता है जंग में जाते हुए. हाँ, so at birth, what is the hearing speech language? Cries and respond to sound. At 3 months, turn to the sound at the level of the ear and babbling. At 6 months, turn the head to the voice and say mama. And at 12 months, 2 to 3 words. At 18 months, 6 to 10 meaningful words. Show 2 parts of the body. And at 2 years, he makes simple phrases. At 3 years, he talks constantly in 3 to 4 word sentences. So at 4 years, he will be able to do counting up to 10. Then this is a favorite MCQ. When will the child get a social smile so that NEET PG preparing mama will be recognized as his mama? Whole world में से seat मिलेगा या नहीं मिलेगा, but your newborn baby at 6 weeks will say, "Don't worry, mama, तुझे NEET PG seat मिलेगा." At 3 months, he smiles spontaneously. He will be laughing. At 6 months, he will recognize the mother. even though her life is messed up in preparation for entrance exam. At 8 months, he understands no and says bye-bye. At 10 months, he waves bye-bye. At 12 months, drinks from a cup with 2 hands. At 18 months, holds the spoons and gets the food safely to the mouth. At 3 years, he is dry by night. This is a favorite MCQ. At 4 years, he can undress and comb the hair. And at 5 years, he can able clothes and do large buttons. That is a short story, Doctor. That is the short story. Inevitable truth about NEET PG, but marna padega. Webbing of the neck, Turner syndrome, gonadalogenesis, ataxia, telangiectasia. How to recognize it, doctor? Cyano-pulmonary disease, chromosomal breakage disorder. There is IgA deficiency, and the defective gene is basically called ATM gene. So telangiectasis, immune deficiency, cyano-pulmonary infections, malignancy. This is a favorite MCQ of examiner. Is ataxia, telangiectasia, which is a chromosomal breakage syndrome, is it pre-malignant or not? So many times it is asked in the NEET PG exam. A 10-year-old boy with fracture of the femur, serum calcium बढ़ गया, hypercalcemia. Serum phosphate कम हो गया, alkaline phosphate is elevated. What is your diagnosis? It is hyperparathyroidism. Always the simple rule. Hyperparathyroidism is synonymous with hypercalcemia. Hypoparathyroidism is synonymous with hypocalcemia. Only difference is how to differentiate primary, secondary and tertiary. अच्छा भाई, primary hyperparathyroidism क्या होता है? If the parathyroid glands are having an adenoma that is producing excessive PTH. So primary ho या secondary or tertiary, in all the 3 PTH is elevated. Calcium is elevated in primary and tertiary. Then what is secondary? Whenever there is a chronic renal failure lead to vitamin D deficiency. That lead to hypocalcemia. And that stimulates the parathyroid glands to produce PTH. And that lead to the dissolution of the calcium which is there inside the bones and release the calcium into plasma. And that makes a low calcium to become at most normal calcium, not high calcium. So the only hyperparathyroidism where normal to low calcium, secondary. There is hyper, primary and tertiary, दोनों में calcium is high. Then vitamin D levels are low in secondary and tertiary, not in primary. And phosphate is low in primary because primary is because of parathyroid adenoma, and it will go to the kidney. It will cause the retention of the calcium and loss of phosphate into urine. Because with phosphaturia, primary hyperparathyroidism leads to low phosphate. But secondary hyperparathyroidism क्या होता है? Renal failure में होता है. Renal failure होता है phosphate retaining condition. That is the reason. The main differentiator between primary and secondary क्या होता है? Phosphate levels. Phosphate level is high, माने secondary hyperparathyroidism. Phosphate level is low means primary hyperparathyroidism. Then one more point. Calcium is low to normal in secondary. Calcium is high in primary. That is how you differentiate. A 9-month-old boy. Then one more point you should remember. What is tertiary hyperparathyroidism? Typically, when the parathyroid glands are hyperplastic and independently functioning for a long period of time in renal failure, typically they continue to hyperfunction. So they, tertiary hyperparathyroidism are autonomous, independently functioning parathyroid glands in renal failure. So that is the reason renal failure is a state of hyperphosphatemia. That's the reason tertiary also has got hyperphosphatemia. That's what you need to remember. A 9-month-old boy, severe pallor, low mean corpuscular volume, hemoglobin 3.8, target cells are there, erythroid marrow expansion is there on X-ray. So what is your diagnosis? Microcytic hypochromic anemia with erythroid marrow expansion. There is no other diagnosis than iron deficiency. 5-year-old boy, fever, that means neutropenia. Petechial spots, thrombocytopenia. And normal, typically splenomegaly. So, if splenomegaly is there, it is unlikely to be ITP, because it can't be ITP. So, what is the other likelihood? Acute leukemia. Acute leukemia. A 5-year-old full-term infant, severely cyanotic. Severely cyanotic. अच्छा भैया, cyanosis बोले तो आपको याद क्या याद आएगा? For tetralogy, transposition, truncus arteriosus, tricuspid atresia. So in him, prostaglandin E was given, mainly to keep the ductus patent. Ductus you want to keep patent temporarily. And then later atrial septostomy was done. So what is your diagnosis? So you should remember, whenever there is a transposition of the great vessels, क्या हो रहा है? Transposition of great vessels means from the right ventricle निकल रहा है aorta instead of left ventricle, and left ventricle निकल रहा है pulmonary artery instead of from right ventricle. So थोड़ा reverse हो गया transposition. अच्छा reverse हो गया तो क्या करना है? अगर reverse हो गया तो you have to provide a way by which once more the blood will go from right to left side. So temporarily you can do that by keeping the ductus arteriosus patent. Permanently you can do it by creating a atrial septal defect by doing septostomy. So that is the reason we do in transposition of great arteries. PGE2, keeping ductus open until definitive surgery, balloon atrial septostomy to let atrial level communication between left and right sides, which got mismatched. Currents about, even a newborn baby will answer this question correctly. Tetralogy of Fallot. So this is the typical shoe, French shoe. The upturned tip of the ventricle due to the right ventricular hypertrophy gives that core and sabot appearance in top. There's a bronchopneumonia, cough and fever. So what are the viruses that lead to bronchopneumonia? Parainfluenza, influenza, respiratory syncytial virus, COVID virus, all these viruses, not mumps. So basically, how do you differentiate anemias, doctor? Legionella, Mycoplasma, Chlamydia, Rickettsia. They lead to atypical pneumonias. Then viral is most common cause of pneumonia in children less than 5 years. Adenovirus, RSV, influenza, CMV, HSV. That is what you need to remember. In neonatal cholestasis, when the gamma glutamine transferase is elevated, what is the possibility? It is the classical feature of biliary atresia, is what you need to remember. When will the last question for today's evening? मेरे प्यारे भारतवासियों, every day 6 p.m. भूलना नहीं. Dr. Murali Bharadwaz will be waiting for you. You will have 50 MCQs as a quiz, and there is a discussion after that. So, when will adult kidney level ka concentrating ability the kidney will achieve? By about 1 year of age. So that is all the story, doctor. Thank you. Abhi aa gaya maza. I hope by this upcoming Sunday we will finish 600 MCQs in pediatrics. Already 100 ho gaya hai. Usme as many concepts we will finish the revision. Okay. So don't forget to subscribe to the crash course. 90 days crash course, December 13 to March 13, with 150 hours of live online session with Dr. Murali Bharadwaz touching all 19 subjects, and also 427 hours of HD video on the onlinemmbbs.com, 30 full-scale NEET PG grant tests for practice, 10,000 MCQs as the quiz tournaments on the Incus and 10,000 PowerPoint slides of notes of high yield facts. See you all once more tomorrow at evening 6 p.m. Good night.